So GERD, reflux of the stomach contents go into the esophagus, right? Diagnosis of GERD is usually based on symptoms. There's really not a whole lot we can do in terms of testing to look at GERD and also response to acid suppression after an empiric trial. So it's a primarily disorder of the lower esophageal sphincter, the LES, can be caused by transient lower esophageal sphincter relaxations, otherwise known as TLESRs. They're brief moments of lower esophageal sphincter tone inhibition independent of swallowing. So we get these brief little spasms where the sphincter, which is supposed to open and close, stays open briefly, where then, of course, you've got the stomach contents coming back up into the esophagus. Other factors include reduced lower esophageal sphincter pressure, hiatal hernia, impaired esophageal clearances, and delayed gastric emptying. So the classic and most common symptom of GERD is heartburn. It's a burning sensation in the chest, radiates towards the mouth as a result of acid reflux into the esophagus. Notably, GERD is a common cause of non-cardiac chest pain, and a lot of patients unfortunately end up in the ER because they're having GERD, right? So it kind of mimics heart attack. Extraesophageal symptoms are more likely due to reflux into the larynx, resulting in throat clearing and hoarseness. So if you have patients who come in who are continually needing to clear their throat or even feeling hoarse, it could be a result of GERD. It's not uncommon for patients with GERD to complain of feeling fullness or a lump in the back of their throat, may trigger bronchospasm, can also exacerbate underlying asthma, leading to cough, dyspnea, and wheezing. Some patients may also experience chronic nausea and vomiting as well. So left untreated GERD can result in several serious complications. One of the most common is esophagitis or Barrett's esophagus, and this may lead to gastrointestinal bleeding. And of course, then, as I mentioned earlier, that can cause background anemia, can cause hematemesis, which is the vomiting of blood, coffee ground emesis, melena, and when especially brisk, hematochezia, which of course is blood in the stool. It does have the potential to progress to adenocarcinoma of the esophagus, again, making this detection of this condition very important, right? We don't want this to progress. Oh, I love these commercials for Tums, Antacids. So bet you can't eat just one Tums. So my understanding of this, the advertisement, is that they're recommending people just eat these things nonstop. Go ahead, have more than one. Have 3, have 5, have a whole pack. So, and then of course here we have raise a Tums to the ultimate summer. This is a gigantic hot dog with all kinds of things that looks like it potentially can cause GERD. So as long as you have your Tums, eat your chili cheese hot dog. So Antacids, that brings us to this conversation, are a group of drugs that have been on the market for many years. They were initially the first line defense against peptic ulcer disease. However, the discovery of our amazing proton pump inhibitors revolutionized the treatment of peptic ulcer disease. So antacid use is restricted to relieving mild intermittent GERD associated with heartburn. So they consist of different types of carbonates or salts. We have calcium carbonate, we have magnesium and aluminum salts in various compounds or combos. And the effect of antacids on the stomach is due to partial neutralization of gastric hydrochloric acid and inhibition of the proteolytic enzyme pepsin, which of course helps to unwind proteins in the stomach. A meta-analysis conducted in 2007 reported that over-the-counter medications showed effectiveness in providing relief from acid reflux symptoms of GERD, and they also help to improve postprandial gastric symptoms. So they work relatively well, and they reduce stomach acidity at what cost? That's the question. So adverse effects are prominent in the infant and the elderly populations. A lot, of course, of older adults are popping these things like candy. And the chronic use of these medications is not recommended due to safety concerns. Aluminum use is associated with increased risk of toxicity in individuals with renal failure. It may include side effects like osteopenia, microcytic anemia, and neurotoxicity. And this is a controversial and heavily debated possible link to dementia, aluminum. But basically, it has been shown that small amounts of aluminum are needed to produce neurotoxicity. It does sequester different types of transport mechanisms to move across the blood-brain barrier. Small amounts of aluminum over a lifetime favor its selective accumulation in brain tissue. And since 1911, there has been some experimental evidence that has shown chronic aluminum intoxication produces hallmarks of Alzheimer's disease. So other types of antacids, calcium carbonate side effects include abdominal pain anorexia, constipation, acid rebound, nausea, vomiting, and flatus. So in general, antacids should never be used in patients. This is a contraindication for renal failure, heart failure, edema, cirrhosis, hyperparathyroidism, and achlorhydria. And I wonder how many of these patients who are taking these things and popping them like candy know about these contraindications or what potentially can be caused by it. Achlorhydria, by the way, a lot of patients think that they have hyperchlorhydria, but a lot of patients actually have achlorhydria or hypochlorhydria. And if patients are taking these things and popping them like candy, it can cause worsening of these types of problems, especially in older adults who lose production of a variety of different types of enzymes. And so, we really have to be careful and be more mindful about some of these medications. And that brings us to the amazing topic of proton pump inhibitors. They're amongst the top 10 most widely used drugs in the world. 2017, 80 million prescriptions given out for meprazole and pantoprazole, Protonix. Also over-the-counter PPIs like esomeprazole. These are just great medications. So anything ending in omeprazole is usually a proton pump inhibitor. So how do they work? They irreversibly block the hydrogen potassium ATPs. Kind of important enzyme system on parietal cells, which are the final step in gastric acid secretion. This increases pepsinogen and gastrin and lowers pepsin and hydrochloric acid. So it really is screwing with the balance of the enzymes in the stomach overall. So you can see we have a variety of things that are supposed to bind to the receptors on our parietal cells. And eventually we have this process that happens with a variety of secondary messengers, protein kinase system that eventually activates our hydrogen potassium ATPase. Here, proton pump inhibitors block the production of hydrogen, thereby lowering acid. That's basically how it happens. So clinical considerations in patients on PPI. Short-term PPI therapy is generally well tolerated and safe. However, their extensive long-term use is a major global issue. They were originally designed to be used for a period of 6 to 8 weeks to heal ulcers, but now we're seeing people on these things lifelong to provide symptom relief and protection against not only stomach acid, but of course, to prevent ulcers as well. Hypergastrinemia, lasting anywhere from 8 to 26 weeks after long-term PPI use is discontinued, is believed to play a role in rebound hyperacidity when the PPIs are discontinued. And that happens to the majority of patients who stop these things, especially stopping them cold turkey. They get rebound hyperacidity. Hypochlorhydria and nutrient deficiencies can also result. So this can cause increased risk of infections, malabsorption of nutrients, minerals, and vitamins, increased risk of a variety of different types of metabolic functions, including osteoporosis, and it can impact vitamin B12 absorption, vitamin C, calcium, iron, and magnesium absorption as well. So here are some of the research out there in terms of PPIs and their potential effects long-term. You can see here potentially leading to things like Clostridium difficile, vitamin B12 deficiencies, having low levels of magnesia or calcium, also potentially causing enteric infections, structural and functional changes in the mucosa, et cetera, et cetera. And so PPIs really are just not very safe overall. So unfortunately. Really, the other thing that PPIs that we don't talk about enough with PPIs is that they cause profound changes in the gut microbiome. And what has been shown is that the changes may actually be just as prominent than the changes associated with antibiotics. This is fascinating to me. We always talk about antibiotics as destroying the gut microbiome, but we need to truly think about other mechanisms by which the microbiome is disrupted. And so many people are on PPIs, right? So, and part of the issue here is that the acidity forms one of the main defenses against the bacterial influx that accompanies ingested food and oral mucus. PPIs help to reduce the acidity of the stomach, unfortunately, allowing more bacteria to survive this barrier and going to where they don't belong. So PPI use is associated with increased risk of enteric infections. A meta-analysis of 23 studies comprising almost 300,000 people showed a 65% increase in the incidence of C. difficile-associated diarrhea amongst patients who use PPIs in healthcare-related settings. Do you have a patient who has chronic diarrhea or has repeated enteric infections, what medications are they taking? So because of the disruption in normal microbiome, the increased risk of enteric infections, this could lead to IBS and or SIBO. Up to 40% of patients with IBS have comorbid GERD. So 40% of patients have IBS and GERD at the same time. 30 to 50% have overlapping dyspepsia. A recent cohort study revealed that 44% of patients with IBS received a PPI, a percentage that's much higher than non-IBS healthy controls. And hypochlorhydria is also a risk factor for SIBO. So really interesting connections here, again, between stomach acid and what goes on later in the gastrointestinal tract, including IBS and SIBO. So we need to ask our patients about medications. All right, so this was a study here. They did a hydrogen breath study of both IBS and SIBO patients who used PPIs for 36 months. They showed that SIBO was detected in 50% of patients using PPIs, 50% of patients, and 25% of patients, a quarter, with IBS, and 6% of healthy control subjects. So again, here we've got PPI use for 3 years showing up as SIBO and IBS. And the prevalence of SIBO increased after just 1 year of treatment with PPIs. So really, really interesting stuff. So nutritionally, what can we recommend for patients with GERD? The only proven lifestyle modification for the management of GERD is head of bed elevation. So obviously helping to elevate the head above, as patients are sleeping to make sure that the acid doesn't reflux. So head of bed elevation. The other things that sometimes we don't give enough credence to is chewing. Mastication, chewing food more thoroughly helps to break down food better. And the saliva enhances the integrity of the esophageal mucosa. So chewing, making sure that patients chew their food enough is very important. Also, mindful eating. A lot of us these days, we're staring at our phone, we're staring at our computer, we're watching a show, whatever we're doing. We're not really thinking about that aspect of chewing and how very important it is for helping to stimulate the gastric juices and making sure that they are secreted properly. Meal timing is very important. Eating at least 2 hours before bedtime, cutting down on high-fat, high-calorie meals before bed, avoiding caffeine-containing foods, especially for those with GERD. Caffeine has been shown to lower the lower esophageal sphincter pressure by stimulating gastric acid secretion, and that includes chocolate, coffee, and tea. Yes, I said chocolate. Unfortunately, it does have a little bit of caffeine in it. Avoiding alcohol, that is also a known trigger, and other types of foods like citrus foods, tomatoes, onions, spicy foods, and spicy herbs like peppermint and spearmint also sometimes cause GERD too. A low-carb diet has been shown to potentially help, and food sensitivities and reducing stress are also potential items in which can very much help GERD as well. Here's a couple of products that I think can be very helpful for your patients. I really like DGL, but this is a product here from BioClinic Naturals. It's got 400 milligrams per chewable tablet. So 1 chewable tablet with each meal, maybe 2 at the heavier meals. But you can also have patients take it after a meal as well, and will cause the same reaction. So I really, really like DGL. It works for a lot of patients. I would say over 70% of patients it works pretty well for. Slippery elm, again, as we mentioned earlier, for helping to heal ulcers. It's not necessarily going to reduce acid production, but it will help to soothe the gastrointestinal tract. 1 rounded teaspoon per day for healing of gastric mucosa and prevention of GERD. And then lastly here, aloe vera juice, fresh aloe vera juice. This is one from Lakewood, organic pure aloe juice, inner leaf with organic lemon. Very, very good, tastes pretty good, and can be very helpful for soothing the stomach lining.